Hello everyone and welcome to today's webinar. We're talking about Medicare evaluations and reevaluations for therapy services. My name is Zachary Edgar. My company is called Therapy Comply. And just as a disclaimer, this presentation is for informational purposes only. None of the material is intended as legal advice. Therapy Comply is a membership-based compliance education and consultant firm specifically for physical, occupational, and speech therapy. We have continuing education courses, guides on Medicare, TRICARE, HIPAA, NCCI, OSHA, and other important compliance issues. We're also working on all 50 states for PT, OT, and SLP compliance guides, Medicaid, workers' comp, really everything. And also for our members, we offer ongoing and comprehensive support for our members. So if you have any questions, compliance or billing questions, you can always email us or schedule a call and we'll be happy to answer that. All right, so evaluation. So important rules to start off with. The initial evaluation must be performed by a clinician, and that's either going to be a physical therapist, occupational therapist, or a SLP. Therapy evaluations can also be performed by physicians, but traditionally they're going to just be performed by therapists. They must be performed prior to any therapy services, and the codes are untimed and they're billable as one unit. The medical necessity of an evaluation. So it's going to be appropriate for a new patient who has not received prior therapy services, a patient who has returned for additional therapy after having been discharged from a prior therapy services for the same or for a different condition. Time spent evaluating for the returning patient should be coded as a new evaluation and not a reevaluation. Prior discharge may have been due to one of the following: the patient no longer significantly benefited from ongoing therapy services, patient no longer required therapy services for an extended period of time, the patient experienced a significant change in medical status that necessitated discharge. Now, while you're allowed to do this, be careful here, because when you discharge a patient, Medicare does expect the patient to be finished with therapy. So if you have multiple patients coming back within a month, within even a shorter period of time, and doing another evaluation, that can put up a red flag for Medicare, because Medicare is only looking at the claims you're filing, and if you're filing multiple new evaluations for the same patient close together, they are going to get suspicious and wonder why you're doing that. So if you are doing that too much, you may get red flagged and you'll have documentation requests from Medicare, which isn't good for anyone. So be careful. Make sure when you discharge a patient, they are not expected to return anytime soon, that they really do not need any more therapy services. On another note, if you have a patient who needs to step away for therapy for a family issue, for a vacation or something like that, you don't necessarily have to do a discharge. You can just do a pause on therapy, put it in the patient's documentation that it's paused, and when the patient comes back, you can do a reevaluation or just continue with therapy, but you don't need to do a formal discharge. And also another reason for an evaluation, new evaluation, was the patient who is currently receiving therapy services and develops a newly diagnosed and unrelated condition. So if the patient's in for rehab on a knee surgery and they hurt their shoulder in an unrelated accident, you can do an evaluation for their shoulder and start and include that with the plan of care. However, if you do that, you're going to need a new physician signature on that new plan of care. All right, moving on. So an evaluation requires a diagnosis. Typically, your state law requires that diagnosis by physical occupational speech therapy is limited to something that's within the scope of practice, so pay attention to that. In most cases, you're going to have a medical diagnosis from the physician or MPP if you have a referral, and then you have your impairment-based treatment diagnosis related to the therapy you're going to provide. The treatment diagnosis may or may not be identified by the therapist depending on the scope of practice. So again, remember your scope of practice and how that, and what you can do within that scope, what you can diagnose within that scope. Just as a note, we do have all the scope of practices for PT, OT, and SLP on Therapy Comply. So you can take a look at that. Also very important in evaluation are your measurement instruments. So this is a list of measurements that CMS just suggests. They are a little dated. You really can use any generally accepted therapy measurement. The important thing is to be consistent throughout the episode of care. When you start your evaluation, you'll want to continue using that same measurement for each progress report to show that the patient is progressing and that therapy is needed. Objective impairment testing. So testing done to determine the source or cause of the functional limitations, such as range of motion, manual muscle testing, coordination, tone assessment, balance. You want to use concise and objective measurements. Avoid minimal, moderate, severe types of descriptions when more specific definitions or measurements are available. So for an example, when measuring shoulder flexation, you're going to document the degrees of motion rather than just saying shoulder flexation has a minimum loss of motion. So you want the actual degrees. Numbers are the best way to go, not just descriptive adjectives on the patient's condition. And use comparative measurements. So acceptable comparative measurement. At the time of the initial evaluation, it was documented that the patient had an objective manual muscle test of 3/5 for right knee extension. Documentation in the 10th day progress report supported that the patient had achieved a 4/5 for right knee extension, which demonstrated a significant benefit for the patient. So this is the kind of documentation that Medicare really wants to see. They want to see you use a specific objective measurement at the beginning of the evaluation and continue using it on each progress report. And remember, those 10 days, it's every 10 treatment visits. You can do them shorter, and you're going to use that same objective measurement again to show that the patient has been progressing in treatment, or if they have not been progressing, why therapy continued therapy is necessary. So that's really where you showcase the medical necessity of continued therapy services. Unacceptable comparative measurements. So at the time of the 10th day progress report, the documentation supported that the patient had objective MMT of 4/5 for right bicep flexation. At the time of the 20th day progress report, documentation supported that the patient was able to complete 3 sets of 10 repetitions for right bicep flexation during each therapy visit. So see, what's unacceptable is that they used a different way of measuring the same condition. So you want to use the same exact measurement, the same type of objective measurements, numbers and everything for each time you document that. Illness, severity, or complexity. So this is also an important part of the evaluation. Identification of other health services can currently be provided for this condition. So it could be physician services or the services of another therapist, a chiropractor, respiratory, social services, anything like that that's related to the patient's condition. Identification of DME needed for the condition. Identification of number of medications the beneficiary is taking, if that is known. If there's complicated factors, complexities that will affect treatment, describe why or how. Documentation should indicate how the progress was affected by the complexity or the severity of the patient's condition as reported on a functional measurement tool, and may be so great as to just extended treatment is anticipated. So all that information needs to be included within that evaluation, and again reflected in each progress report. Generalized or multiple conditions the patient has in addition to the primary condition being treated, another disease or condition being treated, or generalized musculoskeletal conditions or conditions affecting multiple sites, and these conditions will directly and significantly impact the rate of recovery. Any mental or cognitive disorder that the patient may have that can impact recovery, and identification of factors that impact severity. So anything like that is going to be included within your evaluation. You're also going to want to include any medical care prior to the current episode. So record of discharge from a Part A qualifying inpatient, hospital, skilled nursing, home health, anything like that within 30 days or longer if it's relevant to the patient's condition. Identification of whether the patient was treated for the same condition previously by the same therapy discipline, regardless if you were the therapist, if that patient has had prior therapy, you want to document that. And remember that if that patient has prior therapy within the year, that is going to be included for KX modifier purposes. record of a previous episode of therapy treatment for the same or different therapy discipline in the past year. Going to also include notions about the patient's quality of life. So you can ask the patient at the present time, would you say that your health is excellent, very good, fair, poor? If the beneficiary can't respond to that, you're going to indicate why. Patient social support, so you're going to note if where the patient's currently staying, if they're in a private home, skilled nursing, anything like that. Do they live with another person, someone that can help them out, a caregiver that can be trained to help them, and that you can ask questions for? If not, why? Any of those are going to be relevant to the patient's condition and important to their evaluation. The functional status. Remember, functional reporting, those measurements those are no longer required, but you still want to include the patient's functional status, the therapist's clinical judgments or subjective impressions that describe the current functional status of condition being evaluated, when they can provide further information from those measurement tools we discussed earlier. Now, evaluation can be the only service performed. So it's like if a physician wants to recommend that a physical therapist, occupational therapist, speech therapist give the patient an evaluation to see if they need further services, and you determine that they're not, you can still bill for that evaluation, but there are some conditions. So when an evaluation is the only service provided by a therapist in an episode of treatment, the evaluation serves as a plan of care. If it contains a diagnosis or if it states where a therapist may not diagnose, a description of the condition from which a diagnosis may be determined by the referring physician or PP. The goal, frequency, and duration of treatment are implied in the diagnosis as a one-time service. The referral order of the physician is the certification that the evaluation is needed and the patient is under the care of the physician. So if you have that referral, that's all you need. You don't need a new signature on that plan of care. But if you don't have a referral of order and you just do an evaluation, you should go back and get that plan of care signed and dated by the physician or NPP. So this is going to be when the evaluation is the only service, the referral order and the evaluation are the only required documentation. Of course, you're not going to do any therapy, so you're not going to have notes or progress reports or discharge or anything like that. The referral order dated after the evaluation should be interpreted as a certification of the plan to evaluate the patient. So it is okay to have a referral after you do the evaluation. The time spent in the evaluation shall not be billed as treatment time, and again, you're just going to bill that 1 unit for that evaluation. So just a note on speech therapy evaluation, speech language pathology evaluation services are covered if they are reasonably necessary and not excluded as it's a routine screening. The SLP will employ a variety of formal and informal speech language dysphagia assessment tests to ascertain the type, causal factors, and severity of the speech and language or swallowing disorders. And although hearing screening by SLP may be part of an evaluation, it is not billable alone as a separate service. All right, some important things not to do for an evaluation. Do not bill for the therapy initial evaluation on more than 1 date of service. If an evaluation spans more than 1 day, the evaluation should only be billed as 1 unit for the entire evaluation service, billed on the day that the evaluation was completed. Do not count therapy treatment, the additional minutes needed to complete the evaluation during subsequent sessions. You're also not going to bill any test of measurement, range of motion, manual muscle testing, any sort of other evaluation service, assessment service, anything like that, physical performance, any of those, you're not going to bill on the same day as an evaluation. That's going to be prohibited by the NCCI, so those will be automatically rejected if you file those claims. Do not bill therapy screenings utilizing the evaluation codes. Screenings are not a Medicare billable service. Evaluations for deconditioning after hospitalization, where it's anticipated that the prior functional abilities would spontaneously return through patient, caregiver, or other nursing activities, are not considered medically necessary. Preoperative evaluations performed routinely to ascertain the patient's post-surgical needs and or to explain the services that were provided post-surgery are not going to be covered. The patient's post-op experience and functional limitations are going to be unknown, and so you're going to only be able to do the evaluation after that post-op experience has occurred. Okay, now into reevaluations. So these are important as many therapists get this wrong and they bill for these incorrectly. So just to note, a progress report is not a reevaluation. A progress report is something you do every 10 treatment days. You have to do that even if the patient's condition is the same. You don't bill for that. It's just documentation, and you do not bill a reevaluation when you do a progress report. Medicare can pick up on that. If they see that you're billing a reevaluation every 10 treatment visits, that will be a red flag for them. As well, any sort of frequently billing for reevaluation. So, and the rule for the Medicare rule is that reevaluation is separately payable and is periodically indicated during an episode of care when the professional assessment of a clinician indicates a significant improvement or decline or change in the patient's condition or functional status that was not anticipated in the plan of care. So you only get to do a reevaluation when the patient's condition significantly changes. They're not routine, it's not reoccurring, but it's focused on evaluation of progress towards current goals, making a professional judgment about continued care. All that is not going to be done during evaluation. That routine is going to be the progress report. The reevaluation is only covered when the documentation supports that there's been a significant change and that further tests, new measurements need to be done. So remember that it's not a routine event. It's something that only happens when the patient's condition significantly changes. Another important note is that when the patient's when the patient's condition significantly changes and you change the plan of care, if you change the long-term goals, you need a new physician signature on that plan of care. If you only change short-term goals, if you only change frequency, duration, or type of therapy you're going to be provided, you don't need a physician signature. Only when you change the long-term goals will you need a new physician signature. Indications for a reevaluation include new clinical findings, a significant change in the patient's condition, or failure to respond to therapeutic interventions that were outlined in the plan of care. So when reevaluations are done for a significant change in condition, documentation must show a significant improvement, decline, or change in the patient's diagnosis, condition, or functional status that was not anticipated. So basically just repeating what I had said before, but it is important that you remember that you can only do a reevaluation when there has been significant changes, and those changes need to be documented. And a reevaluation should contain all the applicable components of the initial evaluation and must be completed by a therapist, so not by an assistant. Reevaluations are untimed, billable as one unit, and you're also not going to bill for reevaluations as unlisted codes, and you're not going to bill measurement codes, range of motion, MMT codes, any of those on the same day you're going to do a reevaluation. So that's also going to be an NCCI Pro barrier as well. So you won't be able to do that even with a modifier. Speech therapy reevaluations. So reevaluation of patients for whom speech, language, and swallowing were previously contraindicated is covered only if the patient exhibits a change in medical condition. So again, same thing. Only when the patient has a significant change will you do a reevaluation for speech therapy. Monthly reevaluations, Western aphasia battery for a patient undergoing a rehabilitative SLP program are considered part of the treatment session and not covered and they won't be covered if you bill for a reeval. All right, well, that basically sums everything up for today. I want to thank everyone for joining this short webinar. And if you want more information about Therapy Comply, please visit us at www.therapycomply.com. Thank you and have a wonderful day.